Okay, what I would like to do is start off with discussion of two disorders that are really common in the chronic pain population. And the reason for starting with these two disorders is that if you have them and they're not getting treated or they're not getting successfully treated, everything else that I'm going to talk about will fail. Not to be too negative about it, but you just can't progress if either of these things are present. So depression. And when we talk about depression in this context, I'm talking about a very specific kind of depression. Sometimes we call it major depression. It's also called clinical depression, or if you really want to get fancy, we'll call it endogenous depression. And what that means is there is a neurochemical dysregulation. So this is a biological thing. This is not something that you feel in a fleeting way in response to some sort of thing that's happened in your life that's a negative thing. It's not a bad mood, but it is a disorder. And so let's look at it more closely. So at least one of the symptoms have to be present: depressed mood, or loss of interest or pleasure. And here's the significance of this. When I use the term mood in this context, I'm talking about the way you as a patient or you as an individual feel about yourself. And it is true that some people have depression and yet deny it. So if I ask them as a clinician, do you feel depressed? They'll tell me no, when it's clear to me that they are. So that's why we have two things here. The other one is loss of interest or pleasure. So the person may say, no, I'm not depressed, but they don't enjoy things anymore. And that suggests that they are in fact depressed. People sometimes don't want to admit that they're depressed because they think of depression as a kind of weakness, but it is not a kind of weakness. It is not something that you choose. It's not something that happens because people are not trying hard enough. It's a disorder, and it needs to be treated. And approximately 54% of people with chronic pain have it. So 5 of these symptoms: depressed mood, meaning again that you feel depressed, or other people notice that you look depressed, you are tearful, your facial expression is downcast, you don't show the same interest in things that you once showed. So that kind of thing is present. A loss of interest or pleasure in the kinds of things that used to occupy you, used to bring you joy, you used to look forward to them, but they don't capture your interest anymore. They don't move you anymore. Significant appetite change from baseline. So either increased appetite or loss of appetite compared to the way you normally are. Most people with depression experience a loss of appetite, about 80%. 20% have increased appetite. And again, this is compared to your own baseline. At psychomotor, this means the way we move, the way we experience our body as a function or a result of our frame of mind. So if you're psychomotor, if you experience psychomotor agitation, that means you feel restless. You can't be still. You feel antsy and edgy. If you feel psychomotor retardation, you feel heavy, leaden, slowed down, lacking in energy. So, people with depression have abnormalities in this way. Some people feel agitated. It's what I call hand-wringing depression. And other people feel this deadness, fatigue or loss of energy nearly every day, all day long. And of course, it's important to make sure that there isn't some medical cause for this, like hypothyroidism or some other cause. But once we get those things ruled out, it points us in this direction. And it's not something you can talk yourself out of. It's as physical as hypothyroidism or some other medical cause, because this is a biological disorder. Diminished ability to think or concentrate, indecisiveness. The apparatus of the brain, you know, the part that thinks and problem solves, it just isn't responsive. It's boggy. It's slowed down. It's not sharp. And then in very bad cases, people feel like ending their lives. And the real tragedy here is that once the depression is treated, this just goes away. And so if it doesn't get treated and the person ends up taking their own life, it's just a horrible, unnecessary tragedy. How do we treat this? Well, oftentimes we need a medication. And the most effective form of treatment is a medication combined with psychotherapy. All right, let's go to the next slide, please. All right, here's the other big one, anxiety disorder, generalized anxiety disorder. And if we're talking about depression, okay, we'll go back to that for a moment. Any of these symptoms that we talk about lasting 2 weeks or longer starts to raise our attention, like, uh-oh, not good. Anxiety, we have a much longer window, 6 months. And the reason for this is because these feelings that we're going to talk about, they are a normal response to stuff going wrong in your life. I mean, you know, or stuff happening in your life that is demanding. And, you know, any normal person would feel that way. So if it lasts longer than 6 months, it's probably not some response to the situation. And here's the thing, you know, we're not living in a normal time with COVID exploding all around us. So I'm guessing there's probably more of this stuff even than there would ordinarily be, because we're all living in a very, very stressful set of circumstances. Some of us are shut off from family members that we really love. We can't see them. We can't be with them. There's a kind of social isolation that people are experiencing. And I think if you've got the biological predisposition to anxiety or depression, I think it's even more likely that you're going to become symptomatic now, and much, much more crucial that you get it treated. So let's look at the symptoms for this stuff. And again, this is a physical, medical disorder, and so there are physical symptoms. Feeling restless, keyed up or on edge, antsy, not able to get comfortable in your body. Feeling easily fatigued because you're running in this sort of fight or flight state all the time, and it wears you out. Difficulty concentrating, again, this affects the way people think. They can't focus. Irritability, and this is a kind of irritability that sort of gets out of the bag, you know, even toward people that you don't want to be irritable toward, like your spouse or your children or your grandchildren or your dog. You know, these are beings that you love and you don't want to snap at them, but you can't help it. Muscle tension, and this is important because, you know, it makes your muscles sore. And it can affect the muscles of your face so that you clench your teeth. And then, of course, when all of that musculature gets tight and, you know, kind of inflamed because of the constant tension, it makes facial pain of any kind, including trigeminal neuralgia, more likely to occur. And then here is this one, this sleep disturbance one. And, you know, both depression and anxiety show up in sleep disturbance, which just, of course, is like, it just accelerates the whole problem and makes it worse. Anxiety, sleep disturbance, usually difficulty falling asleep. So people will just, you know, they'll get in bed and they'll lie there and they'll toss and they'll turn and they'll, but they can't fall asleep. That's classic. For depression, interestingly enough, the problem is people fall asleep typically fairly easily within 30 or 40 minutes, but then they wake up and they wake up over and over again. So sleep is very fragmented. Again, it's not normal and it causes even more problems. So if either of these things are sounding familiar to you, you need to reach out you need to get some treatment, because it will make everything else that you do of a psychological nature less effective. You really can't beat these things if they're present. They need treatment. And interestingly, both of these disorders, depression and anxiety disorder, are very commonly treated with the serotonin reuptake inhibitors, antidepressants technically, but they also work very well for anxiety. Xanax and other benzodiazepines to treat anxiety disorder, not good. And not good. Causes more problems in the long run. Okay, let's go to the next slide. All right. So I want you to, before I go into the slide, I want you to know, I know that trigeminal neuralgia is a beast. I know that. I know that it hurts so bad when you're having episodes. I mean, it's one of the kinds of pain that when people have it, they can't disguise that they're having it. You know, the grimace and the changes that go onto your face, even if you didn't want people to know that you were in pain, you can't hide it. It's that bad. I know that. So when I talk about the things that I'm about to talk about, please understand, I know how hard this is. But what it does to you emotionally and psychologically is so potentially damaging. We all start off, you know, when this diagnosis of pain of any kind comes along, trigeminal neuralgia comes along, we get a name for it. Oh, that's it. That's what I've got. Oh, okay, that's it. And then you begin to think about yourself in a different way. I'm not the person I used to be, you know, the person before all of this started. Something I can't control, something I didn't choose, and something I didn't deserve has come into my life and changed me. I feel helpless. And in fact, in some ways you are helpless. Yeah. I mean, it's not imaginary, it's real. And when you're symptomatic, you do depend on people around you. But then something starts to happen. Something very damaging starts to happen. You start to see yourself primarily as a patient, primarily, okay, as a person who has pain. And that other identity that you had as a mother or a father or sister, brother, wife, husband, partner, you know, an employee or an employer, all of those things that you used to be, you let go of, and you become synonymous with your pain. And that's not good, okay? It's understandable, but it's not good. And then the other thing that starts to happen is you begin to evaluate other people in terms of how much they see your pain, because this is such a crucial, central thing that's happened to you. And you begin to, evaluate other people. Do they see my pain? Do they take it seriously? Do they think I'm faking? Do they think I'm making too much out of this? So the worthiness of other people starts to get evaluated in terms of whether they regard your pain as serious or not. And then people who don't seem to see your pain or don't understand your pain or minimize your pain, they become invisible to you. They sort of get booted out. And this process that unfolds so naturally over time reduces you to your diagnosis. And that is trouble. All right, let's go to the next slide, please. So chronic pain of any kind, but I argue that facial pain is the worst, because our faces, our identities are here in our face. And anything that affects us there has a very profound effect. What happens over time is we begin to get this is kind of abstract, but I think you'll follow me. What happens is we get detached from our bodies, because the body has become sort of the saboteur. It's become an enemy. And so we begin to pull off this sense of self, the I, the me, out of the body. And this is, again, a natural process. We begin to experience fear that is compulsive and repetitive and catastrophic. And anybody, I mean, I don't have trigeminal neuralgia, thankfully, but I have had many patients who do. And I have seen people having trigeminal neuralgia attacks and facial pain. And believe me, anybody who has that experience is understandably afraid to have another experience like that. So I heard some tapping. Is that anything I should pay attention to? No?
No need.
What?
No worries. Yeah, you can go ahead.
Okay. All right. So what happens when people begin to feel this fear? They become anxiously self-absorbed. And this changes all of their relationships. No villain here. No failure here. This is what pain does to people. This is what pain does to everyone. But it must be challenged, because it will, it will wreck your life. So as fear becomes more and more and more a part of what you're experiencing, there is a loss of emotional range. All the other feelings and emotions you used to have, you don't have anymore. Your emotional experiences become preoccupied by fear of pain and avoidance of pain. And this inevitably causes you to disconnect from people. All right, let's go on to the next slide. So catastrophic thinking, this stuff is bad. And I would challenge you, you're not bad if it's happening to you, but the effect of it is bad for your life. So I encourage you to do a scan as I talk about this, of your feelings and of your experience. And if you spot this happening, let's get on it. Let's fix it, because this stuff will take you down. Catastrophic thinking, the tendency to overestimate the likelihood of negative events occurring, blah, 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 blah. A lot of words, right? But what it means is, once this catastrophic thinking thing has you, it gets you, grabs a hold of you. It means that everything you're doing and feeling and thinking is devoted to avoiding the next horrible thing that's going to happen to you. And it becomes all-consuming. You're scanning the environment. You're scanning yourself. You're looking for the next horrible thing that's going to happen to you. And it becomes irrational. You start to fear things that are unlikely to happen. And I think, trigeminal neuralgia is particularly risky this way, because you have these, I know in type 1, you have these episodes that come out of the blue. They just start happening to you. And then maybe they go away. Or maybe you get on a right kind of medicine and the medicine makes it go away. Or you have a surgery and it goes away, but then it comes back. And it doesn't, it's not really and truly hooked into anything you're doing. It's almost random. But it makes people afraid, because they start to just spend their energy worrying about when the next episode is going to occur. And that means effectively that pain has taken over everything, because there are no periods in between pain where you're not thinking about pain. It's become the center of your life. And that is bad stuff. It's hurtful. All right, let's go on to the next slide. So oftentimes, people who get caught up in this catastrophic thinking have undiagnosed depression or anxiety. And this, again, please don't get caught up in this thought process that anxiety and depression only happens to weak people, or mentally ill people, don't do that to yourself. Because the thing is, you're dealing with something huge. You're dealing with something really, really big. And it is not a weakness to respond to that by becoming anxious or depressed. But it still needs to get fixed. People are afraid sometimes to go out and get treatment because they think that it will mean to other people that the real issue is the depression. It's not really the pain. So if I admit that I'm depressed or anxious, then other people might think that my pain is really overblown, or I'm making a big deal out of it, and it's really a minor thing. Well, that's not true. Some people may think that, but and you can't stop them from thinking it. Sometimes family members think it, and it can be hurtful, but it is not true. It is not true that when you have depression, that the real culprit in your misery is only your depression. Your pain is still a very significant thing. So I think I'd like to go on to the next slide. Let's move on to there we go. So all of the things that I've talked about, all of these things have impact on relationships. And I'd like to spend some time talking about this because I know out there in the audience, since I've done these things when there were real people out there, which I miss, by the way, your partners are out there. It's not just the pain patient, it's the pain patient's significant other or husband or wife that are out there in the audience too. So let's talk about the experience that everyone has. Research shows that people who are in relationships, partnered patients, do better in general. They're less likely to experience depression, and they're less likely to report high levels of pain. But, this is not the whole story. So let's go on to the next slide. When relationships are troubled, when they're going through a rough time, when they're weak and distressed, people do not do well. They report more frequent and intense pain, and they show higher levels of disability. So the takeaway message here is the status of your primary relationship will have an impact on how uncomfortable you are. And this is really hard for people to accept. But if we've got two people, both with trigeminal neuralgia, both having attacks, and one person is in a stable, happy relationship that's doing well at that time, and the other person is in a distressed relationship, the person that's in the distressed relationship is going to feel more intense pain. But that does not mean that the pain is all in your head or imaginary. It's just a very complex effect of the neurochemistry in your brain. But it has to do with the impact relationships have on your mood. Okay, let's go forward to the next slide. So here is this other sort of slippery slope that happens to people coping with pain. Now we're looking at it from the partner's perspective. And in the literature, in the research literature, we use the term solicitous partner. And what a solicitous partner is someone who is trying, okay, nobody can succeed at this. Nobody can. But loving partners will try to meet their partner's every need. So especially when it comes to avoiding episodes of pain. So the solicitous partner is the partner who's trying very, very, very hard to be there for their partner, but it causes trouble, okay? And this is important, so we'll look at it a little bit closer. People who are engaged in catastrophic thinking, who are caught in that net, cannot be extracted from the net by being nurtured. And it's normal, it's natural when you love someone who's caught in that catastrophic obsessive loop always, always, always expecting the bad thing to happen, it's tempting to try and love them out of that, to try and comfort them out of that, nurture them out of that. But it won't work because this catastrophic thing is consuming. So when that happens, when you're with someone who's caught in that catastrophic obsessive net, you need to, if you do anything, okay, the most effective thing that you can do is to get them to go see a counselor, to go see their primary care physician and maybe get on some medicine. But that is the time that you need to reach out for help because A, you can't make a difference in what they're experiencing that way. And B, it actually makes it worse. Because what happens is both partners, okay, in a marriage, but it could be a child, it could be an adult child that you're close to. It could be a friend that you're close to. But what happens is both people get engaged in that hypervigilance for what is going to cause the next episode of pain. Oh, maybe we shouldn't go to that dinner, honey, because, if we go to the dinner outside, the wind will be blowing and maybe it will cause your facial pain to act up, So both partners start looking for triggers and looking for ways to avoid pain. And the pain just starts to work its way into the relationship and take over. It's like this big, Job of the Hutt thing sitting in the middle of the relationship. I'm in charge now. Both people are owned by the pain. And this dynamic will kill intimacy. It kills the very reasons that you fell in love with each other in the first place. It damages relationships. So that's why we have to get away from it. We have to have a better, more successful solution than both people sitting in the middle of a mass of fear trying to avoid triggering pain. Okay, let's go to the next slide. The relationship can feel like it's dying, and yet nobody talks about it because there is nothing more scary in a relationship of importance to people than talking about the fact that it's not going well. People are terrified of that. It's like if we put it out in the open, oh my God, if we put it out in the open, it must mean that we are going to end. We are going to end. But the thing is, not talking about it increases the probability that it will end, either actually come to an end or become so lifeless that it's as if it's ended. But yet it takes courage. And this very often involves the partner of the pain patient saying to the pain patient, speaking out to some degree, in some way, about the fact that they're feeling pushed out of the relationship by the other person's pain. It's like this big, huge pain monster has taken up all of the space. And the caretaker develops a kind of resentment about that. And they feel guilty about it. So now we've got resentment with guilt stacked on top of it. And it's very hard to feel connected when that emotional experience is going on. And so what happens is people begin to behave out of obligation. And the other person can feel it. The pain patient can feel that their partner is connecting out of obligation. And then that causes them to start to wonder if the relationship's in trouble. And it just goes bad. And the only way out of this is for people to sit down and talk about it and to talk honestly, very transparently about your fears and your thoughts and your emotions. And believe it or not, this terribly frightening thing that you're about to do, talking openly, can revive the relationship. It can bring new life to it. Okay, let's go on to the next slide, please. All right, some coping tips. Let's go to the next slide. All right. If you have a history of childhood abuse or neglect and you haven't talked this out in therapy, get into therapy somewhere, because believe me, this is not a good combination. A history of trauma and chronic facial pain, bad, not good. So go talk to someone, and you can talk to someone about the childhood experience of trauma, or maybe you were in a relationship that involved domestic abuse, or it could be all kinds of things. You don't even need to mention your pain, and it will help your pain. Because if you just unload this big burden that you've been carrying for all of these years in silence with somebody who actually can understand, man, the thing about having experienced trauma in the past is very often other people can't understand because they haven't had anything like that happen to them. But I promise you, a therapist who deals with this can understand. They will understand. And that will make a difference. It will help. So if that's there, do right away. Monday, get on the phone and find a therapist. All right, let's go to the next slide, please. And you may need an antidepressant. How do I decide when a patient needs an antidepressant? Well, if their sleep is not good, that's a trigger for me. Like, we got to get something going on. We got to get some medicine on board here. So if your sleep is consistently sucking, and we don't have sleep apnea or some other cause, yeah, let's get an antidepressant on board. And again, without ever talking about your pain will get a little bit better. We know this. It's in the research. Your pain will get a little bit better. Now, here's something to keep in mind, though. A lot of the antidepressants can cause you to brush your teeth. They just do. Not perfect, right? No, they're not perfect. But that bruxing, grinding your teeth, can stir up all of this nerve supply. Not good for somebody with trigeminal neuralgia or facial pain. So if you get on an antidepressant, I would suggest that you go to your dentist, and I know that going to the dentist is not fun, but this is important. Go and get an oral appliance made, which will just help. Just trust me, it will help. And that way you can go on taking the antidepressant, which will be crucial to your happiness. All right, let's go to the next slide. Reach out early. Oh, what's the worst thing that could happen? You could reach out and you don't really need it, or you could reach out and you only need a little bit. That's the worst that could happen. So if you think you might need some psychotherapy, reach out. And if it doesn't feel right, or you think it's helped and you're done, say, so long, I'm done. You don't owe the therapist anything. You don't owe the therapist anything. You don't have to take care of them. That's the beauty of it. Okay, let's go to the next slide. And this is also important. When you have this big thing like trigeminal neuralgia in your life, it's tempting to forget that there are other sources of loss and suffering that are also significant. And those things need to get talked about. And it can get very, very confusing. I've seen this with my pain patients for decades. If you're dealing with this chronic pain monster, you start to attribute every negative affect, every sadness, every anger, every fear to pain. And this is never true. Okay. It's never true that all of that negative affect, every single piece of it belongs to pain. Some of it belongs to disappointments that you have in your life for other things. And they all need to get talked about too. Okay, so it's important not to let that confusion occur. Remember that when that happens, that's because Jabba the Hutt, remember that Jabba the Hutt guy? That's because the Jabba the Hutt pain is sitting in the middle of your head. Okay, let's go to the next slide. It's better to see a psychotherapist who has experience with chronic pain if that's what you want to work on. Because a chronic pain therapist has had so many pain patients that they have certain knowledge and chops that a standard sort of like general psychotherapist wouldn't have. But let me be clear, a general psychotherapist, if you can't find a chronic pain specialist, a general psychotherapist is better than no psychotherapist. It's just that you may have to teach your general psychotherapist what trigeminal neuralgia is. Okay, let's go to the next slide. We're running out of time. I think I am out of time, actually, but let me just say this. Don't mind read in relationships. Don't do it. You think you know what they're feeling, and you may be right, but sometimes you're going to be wrong. So use your words. Talk about what you feel. Ask questions about what they're feeling. It takes courage, and you get better at it. You're really not great at it when you start, but more practice makes perfect, and you can get this mind reading thing out of the way. And let's go to the next slide. Let's see what's there. Do not allow your partner to routinely do for you what you're capable of doing for yourself. Man, that is such a harsh statement. It's so harsh, but it's true. Hold on to what you can do. Hold on to what you can do. And partners, allow your pain patient partner to hold on to what they can do. Don't take over everything. Let them hold on to some of their autonomy. Let them hold on to some of their strengths and some of their skills. Don't let your relationship just become one big merged bomb. Okay? And I think that may be the last slide, but let's take a look. Next slide. That's it. Okay, that's what I got. I hope it was helpful. And so I'll turn it back over to Allie and I'll check out.